Hi, welcome back. So we are now moving on to uro-oncology, and so uro-oncology got a few major cancers in urology. We'll be starting off with the renal cancers, which are the simplest and how to put it, the cancer that has got the least amount of controversies in terms of management, and it's the least complex to manage as well. So we'll start off with the Bosniak system. So we'll be doing a bit about benign tumors, followed by RCC and different types of RCC and the different syndromes. Again, as I said, I'm not going to go into detail as to what individual symptoms of these syndromes are. It's all there in the notes. You can hear about it. What we'll be dealing with is just the concepts. So the Bosniak system is a grading system to see what are the chances of malignancy in a renal cyst. So that is the Bosniak system. The important thing to remember was that it was a system based on CT appearance, not ultrasound, not MRI, contrast enhanced CT. That was what they used to grab this criteria, and it basically has 5 grades: 1, 2, 2F, 3, and 4 in increasing risk of malignancy. 1 being simple cyst, very minimal, next to 0 risk for cancer, and grade 4, which is very high chance of being cancer. So I agree with the percentages that I agree with the description of the cyst, but the percentages vary between different books. I don't think it is relevant. The basic crux of it is that 1 and 2 you can ignore. 2F needs follow-up, 3 and 4 needs treatment. So that is the basic crux of the percentages. So type 1 is a simple cyst. It's a hairline thin wall, nothing inside, no septate, nothing at all. Type 2, it's got hairline thin septations, and none of these septations enhance, so there's no enhancement. And it's the size is less than 3 centimeters. There's no thickening. You may have some calcification, especially on the cyst wall, nothing apart from that. Type 2F, it can have some thickening of the septa, and it's from here that they start getting categorized as complex cysts. And sometimes you also have what's called the hyperdense cyst. If you remember, cysts are fluid, and so the Hounsfield units should be very, very low. But sometimes you've got cysts that are hyperdense. These are still non-malignant, but they can so go to this. They said the risk of disease none. It's very minimal in type 2, not enough to quantify as a percentage. Type 2F, again, 3 to 5%. Hyperdense enhancement, thickened nodular septa, but calcification, but there should be no obvious enhancement. There can be perceived enhancement. This is when you say perceived enhancement, it's because there is enhancement of it appears to be, but there's no measurable enhancement. And type 3 and 4, 50%, 75 to 90%. So from your point of view, what you need to know: type 1 and 2, ignore. Type 2F, you need to follow up. Type 3 and 4, it's green. Again, it's the same thing. So that's about renal cysts. Renal cysts are the most common benign lesions of the kidney. And if you go to renal tumors, oncocytoma will be the benign, most common benign renal tumor. Cysts are not technically tumors, but they are the most common benign lesions. Again, just briefly, Campbell says up to 25% of renal masses less than 3 centimeters can be oncocytomas. For small renal masses, it's difficult to say whether they are malignant or benign, and the biopsies are about 90% accurate. There's still 10% gray area that you may end up doing surgery for a benign tumor. So what are the things that you need to know about oncocytomas? Yes, most common benign renal tumor. It can happen more commonly in females. You can have a central scar or spoke wheel appearance. That's the MCQ based on radiology. But again, this is not pathognomonic. It doesn't necessarily mean if it's a central scar, it's an oncocytoma. Again, biopsy has a low predictive value, mainly because it is difficult to distinguish from a chromophobe RCC. A clear cell RCC has a higher sensitivity. That's about, so said, about 90%. But for oncocytomas, the predictive value is quite low. All cancers have some chromosomal abnormalities. A couple of things that were not mentioned here is these are associated with syndromes such as Burt's and oncocytosis. You've got detailed description of Burt's coming later. Management, you can safely observe them. If they're less than 3 centimeters. You can do transparent surgery. You can do radiofrequency ablation or cryo or active surveillance. Any of these are good enough. So again, that's the MCQ. Highly eosinophilic appearance due to the presence of numerous mitochondria. What are the differential diagnoses on pathology? Chromophobe RCC, STH deficient RCC, and papillary RCC. These can mimic oncocytomas. And just given a little description on how to distinguish between the two. Again, this does not happen in all the cases, but these are the different markers that can be used to distinguish between oncocytoma and chromophobe RCC. And it's called Hale's colloidal ion. It's a common MCQ. What is it used to diagnose? It's usually to differentiate between chromophobe RCC and oncocytoma. Yeah, it says just as CD117 is just to revise and to recollect random things like this so it sticks in your memory. So the next tumor is angiomyolipoma. It's again a benign tumor, and as the name suggests, it's composed of blood vessels, smooth muscle, and fat cells. It's monoclonal in origin. That way, it is a neoplasm. They are generally benign, but when these are associated with tuberous sclerosis and lymphangiomyomatosis, and certain epithelioid variants can metastasize and can invade. So it is derived from perivascular epithelioid cells. It's also called as a PCOMA. And it's got estrogen and progesterone receptors, so hence pregnancy can cause some unwanted changes in these tumors. More common in females, usually in the 4th and 5th decade. And it's same thing repeated again. So what are the genetics of this, it is most commonly associated with tuberous sclerosis. Tuberous sclerosis, as you would know, adenoma sebaceum, epilepsy, and low IQ. That's the sort of triad for tuberous sclerosis. And this basically acts through mTOR. Yes, tuberous sclerosis 1 and 2, chromosome 9, chromosome 16 for you to remember, and it's autosomal dominant. Again, lymphangioliomyomatosis is another genetic disorder, which also has a mutation in the TSC1 and 2 gene, but doesn't necessarily present like a tuberous sclerosis. Why is it important to diagnose if someone with angiolipoma has tuberous sclerosis? It is because they're multiple and bilateral, and they can grow faster. So they're more likely to need intervention, and they're more likely to need very close follow-up. But we need to remember the most common form of angiomyolipoma is sporadic, and more often than not, it is detected incidentally and usually needs no treatment. Again, most common detection is incidental. However, it can cause spontaneous renal or retroperitoneal hemorrhage, which is called as Wunderlich syndrome, and is seen most commonly in AML, but can also be seen in renal cell carcinoma. How do you investigate? Ultrasound. It is seen as hyperechoic lesion on an ultrasound. On a CT scan, intralesional fat. That's the pathognomonic feature. Intralesional fat should raise the suspicion of an angiomyolipoma. Sometimes it's difficult because there are fat-poor AMLs and there are fat-rich renal cell carcinomas. So this is not absolute, but it is one of the predictors that you can use to accurately diagnose this. And again, MRI, sorry, before that, you can have aneurysms within the lesion, and if you've got an aneurysm with a 50% dilatation, then there's an increased risk of hemorrhage. And MRI is hyperintense, and T1 and T2, which is what fat does on an MRI, and India Inc. artifact is the key point you need to remember that's seen in angiomyolipoma on an MRI. So the size cutoff of 4 centimeters, it was historical. There was no sort of credible evidence behind this, but that has been usually followed. If we go, there we go. So we assume that we've diagnosed someone to have AML. So we'll start off from this end of the pathway. So now we're coming on to the management. So we've diagnosed someone to have angiomyolipoma on a CT, and so before we decide what the size of the lesion is, if we decide whether they are symptomatic or not symptomatic, if they are symptomatic, then they will need some form of treatment. And if they are symptomatic, you do germline testing for TSC. So if they do not have tuberous sclerosis, then the management, the only thing that differs is if they have tuberous sclerosis, or if suspect tuberous sclerosis, they can also have everolimus as a treatment option. That is the only difference. If otherwise, you can do the same things. It's RFA cryoablation, partial or total nephrectomy, selective arterial embolization. So selective arterial embolization, we tend to use this as an emergency treatment. And anyone with spontaneous retroperitoneal hemorrhage where you suspect an angiomyolipoma, treatment of choice in that case would be selective arterial embolization. That is the key point you need to take away from here. Symptomatic patient with tuberous sclerosis who does not have hemorrhage can have everolimus. And second one is that if patient presents with acute hemorrhage secondary to angiomyolipoma, treatment of choice would be selective angioembolization. Again, asymptomatic patients who do not have TSC, this should be centimeters and not millimeters. If it's cutoff used to be 4 centimeters, but it is not absolutely imperative that you need to manage everyone. But if they are of childbearing age, or if they're planning on becoming pregnant, it might be good to treat these patients before, because they are known to be these patients can land up with complications during pregnancy. So what they use more commonly is if they have an intralesional aneurysm more than 5 millimeters, that is what is now more commonly used as a risk factor rather than just the size. I hope that's clear. If it's a suspect, so that's for, so this half is for people who are diagnosed to have AML. This is when you suspect an AML. So normally they have a CT. If it's not very clear on a CT, they have an MRI. If it's still equivocal, you can do a biopsy. If it is still equivocal, you treat them as you would do any renal tumor. So based on the size, you can either do you treat them as any renal tumor. It's not all renal tumors you get a histology all the time. So complications, these are both of the tumor and of embolization. You can get hemorrhage, you can get an abscess, sterile liquefaction, renal infarction, and post-embolization syndrome. But open surgery should be avoided at all costs in these patients, because if you do that, what you'll be able to do is only a nephrectomy. Right, so that's the last one. So everolimus is the only drug that has now been approved. And it's only approved for patients who have tuberous sclerosis or LAM. It is not for sporadic cases. Again, they can change malignantly. They can undergo a malignant change, but they can become a leiomyosarcoma, at which point Koncpt can be positive. And as I said, there is an epithelioid variant that can metastasize. So that is the effect of everolimus. So this 50% of reduction in volume, and but 80% achieves at least a 30% reduction in size. That is the effect of everolimus, and if there is any response, they generally don't have any progression, which is good. So as I said, TD could be fat poor AML, liposarcoma, fat containing RCC. So with these, you do a biopsy. If you still can't diagnose, management as any renal mass. Few uncommon tumors, cystic nephromas, MEST. So these are things that we do not see very frequently. MEST is a mixed epithelial stromal tumor. And the treatment for these, because all of these are pathological diagnosis. So this presents more like a Bosniak tree cyst, and the treatment would be surgery. You can cystic nephroma, it will be a complex cyst with some central calcification. It's difficult to get the diagnosis is pathological, that is after you do surgery. So all of these tumors, they'll be managed as management as a renal mass. So all you need to know is few of these points for MCQs. What are they? Who are they common in? Males or females, and which age? And if they've got any weird cytogenetic or immunohistochemical staining, then that will have to be remembered. Like cystic graphoma is got a hobnail appearance and is calretinol positive. So that's something you'll have to remember. Fortunately, that is going to be just memory. Not a lot you can do about it. But thankfully, there's not a lot of these that you have to remember, at least in renal tumors. And the management part is quite simple. Same for leiomyoma as well. It arises from the renal capsule. So that is something that you have to remember. And it is a smooth muscle tumor. So it will be positive for Desmond, it will be positive for Wyman. And management is the same. Reninomas, you need to remember the cell of origin, which will be the juxtaglomerular cells. And it's a tumor from the juxtaglomerular cells. And don't try to read too much into the symptoms. It's all symptoms of hyperaldosteronism that you get, which is what renin essentially does. And diagnosis is by increased plasma renin levels. And management is surgical. And what you have to remember is 10% of patients will still have symptoms after treatment because of angiopathy secondary to hypertension. Hemangiomas is like any other hemangioma anywhere. It's, you can remember the location, close to renal pyramids and the pelvis. Lymphangiomas, another type of benign tumor, and usually incidental, but can sometimes cause obstructive uropathy and chyluria. And it is seen in trisomy 7, monosomy X, and VHL. Solitary fibrous tumor is another type of benign tumor. And you've got more benign tumors, metanephric adenomas, which is a pathological diagnosis. It's a benign tumor. Remember, ADPKD is due to polycystin, ARPKD is due to polydactin, and ADPKDs, renal cysts, and oncocytomas are derived from the distal tubules. We've got a little bit more about this coming up as well. So and as I said before, most common benign lesion is a renal cyst, most common benign tumor is an oncocytoma. So benign tumors, the two things you need to know about are oncocytomas, and you need to know a bit about angiomyolipomas and about tuberous sclerosis. And the rest are, if you've got time and if you can read through the rest of the tumors, but these things you should be absolutely confident about. Bosniak grading, angiomyolipomas, oncocytomas, absolutely confident about these three. So coming to RCCs, or renal cell carcinoma, men, 6 to 8 decade of life. Risk factors are essentially 3: H, O, and T, hypertension, obesity, and tobacco. Apart from this, acquired renal cystic disease, or ESRD, is a risk factor, and they usually form papillary type of tumors. And there are certain occupational exposures that can cause cancers as well, but the three classical ones are hypertension, obesity, and tobacco. Campbell does say that association with diuretics and antihypertensive medications are more prone to form papillary type of RCCs, but you can see both in all of these. Again, RCCs are not very common in childhood, especially in the first decade. They're more prone to get Wilms tumors, but by the second decade, the incidence of RCCs and Wilms tumors are roughly the same. How are tumors in young children different? They present with locally advanced high-grade unfavorable histology, and lymphadenectomy is recommended in young children because it actually improves the prognosis. However, in adults, the role of lymphadenectomy is questionable. So now we're talking about clear cell RCC. So that arises so if you talk about RCC in general, it can arise from both the proximal convoluted tubule or the collecting duct, or some tumors from the distal convoluted tubule. The most common tumor histology is clear cell carcinoma. I think it's easiest if we go to, there we go. We'll do this first and then we'll come back to the rest. So the histological subtypes, most common is the clear cell carcinoma, and this arises from the proximal tubule. So what we need to remember are the basic histological subtypes. We need to remember which arises from where, and what are the syndromes these cancers are associated with. So clear cell RCC, classically associated with von Hippel-Lindau. Papillary type 1 RCC, associated with hereditary papillary renal carcinomas, and it arises from the proximal tubule as well. Type 2 RCC, hereditary leiomyomatosis and renal cell carcinoma syndrome, and that arises from proximal tubule as well. Chromophobe RCC, associated with Birt-Hort-Dubé syndrome, and it arises from the intercalated cells of the collecting duct. And you've got those are the four most common variants. To recap, clear cell, proximal convoluted tubule, VHL, papillary type 1, HPRC, and it's also proximal convoluted tubule, papillary type 2, HLRCC, also proximal convoluted tubule, and you've got chromophobe type, which is associated with Birt-Hort-Dubé syndrome, and it arises from the collecting ducts. So this is the most productive part from an MCQ point of view for renal tumors. Von Hippel-Lindau disease is associated, and whether it's autosomal dominant or recessive for information, they're all autosomal dominants. There are hardly any autosomal recessive mutations in oncology as such. They're all autosomal dominant. Just make sure you keep revising to remember the gene associated and the chromosome associated. So von Hippel-Lindau, it's chromosome 3p25. Papillary RCC is MET proto-oncogene, chromosome 7. HLRCC is fumarate hydratase, chromosome 1. Birt-Hort-Dubé is mTOR, folliculin in chromosome 17. Tuberous sclerosis, you've already seen it. It's chromosome 9 for type 1 and 16 for type 2, and P10 hamartoma or Cowden syndrome is chromosome 10. Yeah, so the only proto-oncogene mutation is seen in familial papillary RCC or FPRC. Key cause of death in VHL is progression of RCC to metastasis. Familial papillary RCC is one of the few where the syndromic tumor is less aggressive than the sporadic type. And even less than 3 centimeter tumors, if they're associated with syndromes, you not for surveillance. So von Hippel-Lindau disease, it is a syndrome that's associated with multiple different tumors associated in all over the body. And the most common is hemangioblastomas in the CNS. That is the most common tumor, and you get RCC in about 50% of patients. And what is the key element? It's HIF2 alpha. It's going to bring about it a bit later, but we can get it now. So the VHL basically acts through the HIF, which is hypoxia inducible factor. So normally these produce vascular growth factors. When the body's tissues are exposed to hypoxia, what VHL essentially does is that it keeps these constantly active. So there is constant proliferation of blood vessels and constant proliferation of tumorigenic substances, and hence the tumor. So that's in a nutshell as to how VHL works. So anyone who's diagnosed to have VHL, you need to screen them for all the different tumors they get. Eye checkup for cerebellar and retinal hemangioblastomas. They can get pheochromocytomas as well. So that's why you measure plasma urinary hematinophrin. Ultrasound is for renal tumors. And we do auditory exam, CNS. So that is the screening pathway that you follow. And how do you manage these tumors? These nephron sparing surgery is the preferred approach. And we try and enucleate these tumors. It doesn't matter if you've got a negative margin or a positive margin in these cases, because they're going to invariably form more tumors anyway. So the least amount of parenchyma that is wasted, that it is better for these patients in terms of renal function. And unlike other tumors, we only intervene when the size is more than 3 centimeters. So again, this is just repetitive von Hippel-Lindau, just to take you through those genes again and again and again. HBRC is CMET in chromosome 7, fumarate hydratase in chromosome 1, Bird-Hawk tubase folliculin in the mTOR pathway. You can get chromophobe RCCs, oncocytomas, succinate dehydrogenase RCC. Again, you can get all different types of RCCs, and it's either chromosome 1 or 11. You know about tuberous sclerosis, you know Cowden syndrome, it's P10 in chromosome 10. So it's just repeated revision. Keep reading this again and again. And there is that's the only way to remember this on the day of the exams. The pathology, all of these are adenocarcinomas that arise from the tubular epithelial cells, be it from proximal convoluted cells or from the collecting duct cells. You do get collecting duct and sarcomatoid variants and medullary variants. These are very rare, and these are highly aggressive. And some of these can respond to traditional chemotherapy. RCCs, for most part, are resistant to chemotherapy because of several mechanisms that they have, which are not very relevant for you. But collecting duct carcinomas, sarcomatoid variants, and these medullary carcinomas can do respond to chemotherapy. So, as we discussed before, distal tubule derived, we've already seen this, ADPKD, sporadic renal cyst, oncocytoma, and chromophobe RCC, proximal acquired renal cystic disease, clear cell, and papillary tumors are from the proximal convoluted tubules. So it's remission, keep reading the same thing again and again. So what we've read, most common subtype is a clear cell RCC, papillaries, So all these three arise from the proximal convoluted tubule. Chromosome is from the collecting duct. Again, these are the uncommon variants like clear cell papillary RCC, which arise in ESRD. These are the ones that are associated with acquired renal cystic disease, or ARCD, which is basically formation of hyperplastic renal cysts that occur in patients who are on dialysis. Normally, after 3 years of being on dialysis, we tend to follow these patients up with serial ultrasounds of their native kidneys to make sure they don't have enlargement of these cysts or renal tumors. Again, collecting duct carcinoma, as I said, can respond to chemotherapy. And which carcinoma is associated with sickle cell trait? It is renal medullary carcinoma. That is an MCQ there that you need to remember. Sickle cell trait is associated with renal medullary carcinomas. So again, this is a form of papillary. We've read this in as a form of papillary carcinoma, but sometimes these can occur separately as well, which is a highly aggressive tumor. And another form of acquired cystic disease associated RCC, which one? When it happens as a clear cell RCC, it can be associated with VHL gene alterations as well. So you've seen there are 2 different variants that are associated with end-stage renal disease. So it's one that can have VHL gene alterations, and the other that can present as a clear cell variant, or it can act as a papillary variant as well. So historically, we used to use what was called as the ferment grading system for grading the aggressiveness or severity of renal tumors. What we now use is the WHO ISUP grading and 4 grades, and we use this grading system into risk stratification as to what's called as the Leibovitz score, and this is to determine follow-up. So the follow-up is not based on just the ferment grade, it's based on the size of the tumor, D stage, whether there was any necrosis, and the grading. And we use all this to design a follow-up algorithm, but that's too complex. All you need to know is it is one of factors that help in grading. So cancers, they all have this TNM staging. And the way to remember is start from the bottom. The center organs, locally advanced or outside capsule. T1 is localized. T2 is usually localized, but it invades a little bit deeper. So that's usually holds true for most cancers or most slight difference between solid organ and hollow viscous tumors, where for solid organs, T1, T2 is predominantly size-based. For hollow viscous, T1, T2 will be based on depth of invasion. This will be lamina propria. This will be muscularis propria. That is what is no matter what cancer you study, that will usually hold true. So this will be size-based. So kidney is I think the plan is we can try and see if I can take video separately, choose about just TNM staging, which will help you for revision for urology. But in kidney cancer, so T1 is up to 7 centimeters, T2 is anything more than 7 centimeters is T2. T3 is not beyond Gerota's fascia, so anything up to the Gerota's fascia, yes. T4 is beyond Gerota's fascia, including the adrenal gland. The reason why that's the case is because the Gerota's fascia splits and the adrenal gland is outside the layer of Gerota's fascia that covers the kidney. If the tumor spreads there, it is T4. So that is a very important point that you need to remember. And the other thing you need to remember is the renal vein involvement on IVC involvement and what stage that comes up to. I think that is where most of the questions will come from with respect to renal tumors. So renal vein invasion is T3A. T3B will be IVC, but below diaphragm. T3C will be IVC, but above diaphragm. The last one is invasion. If it invades into wall of vein, it becomes T3C. So that's why we've got thrombus can be two types. It can be tumor thrombus or bland thrombus. A bland thrombus is generally the one that does not invade. And it's actually quite easy to remove. So it's the tumor thrombus that can some present as T3C causing invasion. Hope this is clear. Just recap again. So T1, anything less than 7 centimeters. T2, anything more than 7 centimeters. Then coming to T4, if it goes beyond the Gerota's fascia, it's T4. If it involves the adrenal gland, it's T4. T3 is in between. And the only important part in T3 that you have to remember in renal tumors is involvement of the renal vein or IVC. If it's just the renal vein, it's T3A. If it's IVC below the diaphragm, it's T3B. IVC above the diaphragm is T3C. Any invasion of the wall of the vein, it becomes T3C. Okay. Yes, N staging and M staging is quite simple. N0 and 1, N0 and 1. So that is quite self-explanatory. So how do we assess for lymphadenopathy? It's on if there is any contrast-resonance CT is the investigation of choice. And if you're able to visualize lymph nodes on the CT, then yes, we don't formally do lymphadenectomies unless you see any obviously enlarged lymph nodes, which you try and remove. But formal lymphadenectomy, which was a part of the traditional radical nephrectomy, is no longer performed as it provides no benefit in overall survival, apart from improving the staging. So what are the landing zones? It's the same as for testicular tumors. It's the entire caval region for right-sided tumors and para-aortic region for left-sided tumors. And we all know what paraneoplastic syndromes are. These are due to cytokines produced by the tumor, and RCC is notorious to produce a variety of paraneoplastic syndromes. The most common would be raised ESR. Second most common is hypertension, And what are the reasons for hypertension? There are several. These tumors can produce renin. They can be an AV fistula within the tumor or as a result of the tumor. They can compress on the renal artery, which causes the normal renal parenchyma around the tumor to produce more renin and thereby causing hypertension. Secondary to that, they can metastasize to the brain. Polycythemia and hypercalcemia are other causes. So if management of these paraneoplastic syndromes, they are usually medically managed. The definitive treatment would be to remove the tumor. So before you do that, if someone has malignant hypercalcemia, the first step is hydration plus diuretics. So that's medicine 101. Any hypercalcemia, the first line of treatment would be hydration and diuretics. If that doesn't work, you then do denosumab and bisphosphonates. And the definitive treatment would be nephrectomy plus or minus metastatectomy. And the other syndrome you need to remember with renal tumors is what's called a Stoffer syndrome. What you need to remember is that this is non-metastatic. That is the key word. It is non-metastatic hepatic dysfunction, and it is reversible. 100% of patients will have rise in serum alkaline phosphatase, and it is due to raised levels of IL-6 produced by the tumor. And treatment is nephrectomy, after which 60 to 70% of cases, the hepatic function would normalize. If there is any presence of viable tumor in micrometastases that are not detectable, then yes, they will still have raised liver function, which is then a poor prognostic. So that's what we discussed before. From third year of dialysis, there is a very high risk for patients to develop RCC. So that is acquired renal cystic disease, which can then progress to a clear cell papillary RCC or a separate ARCD associated RCC, both of which have very poor prognosis. So in general, RCCs, especially clear cell RCC, are hypervascular tumors. That is their nature. That's where they enhance by 20 to 50 Hounsfield units after you give them contrast, but there are certain hypervascular tumors. These are benign. The papillary RCC is a hypervascular tumor. Again, some examples for calcified renal masses: RCC, urothelial carcinoma, benign complexes, XGPN, aneurysms, and nephritis. So these are all differential diagnosis. Let's get to key points in the RCC. It's just way to read, and it's way to remember, as it's essentially a ready reference rather than for you having to search in different places. So let's go to some important facts about RCC. There is somewhat like a 10% rule. 10% have venous involvement, about 10 to 20% have calcification, 10 to 25% have cystic degeneration, paraneoplastic again 10 to 20%, bilateral tumors 10 to 20% in familial cases, and it's 2 to 4% in sporadic cases. So again, key facts just highlighted so it's easy for you to read. You don't have to look in different places. Investigation of choice is a CT scan. For diagnostic, it's a triple phase or renal protocol CT. So what are the three phases? They are the corticomedullary phase, in which hypervascular tumors appear, nephrographic phase, in which you can see small hypovascular tumors because the entire kidney enhances in this phase, and delayed excretory phase gives an indication of the excretory system, so you can see PCCs and in this phase. We do not necessarily include the angiographic phase always in the diagnostic films. They are helpful if you're planning for a partial nephrectomy or in treatment of lesions like angiomyolipomas, if you're planning in a selective embolization. But the classic triple phase renal protocol CT includes the corticomedullary phase, the nephrographic phase, and a delayed phase. And key point is, any lesion that enhances more than 50 to 20 Hounsfield units suggests that it is an RCC. And the same for an MRI as well. So another thing that is important to see is an IVC or renal vein thrombus, because the management is different and becomes quite complex. So how do you detect this? You can see a filling defect, you can see enlargement of the vein, abrupt caliber change, or presence of collateral vessels. And clinically, a non-reducing right-sided varicocele should raise the alarm that there is a IVC thrombus. That is a clinical finding. Non-reducing right-sided varicocele means you should have a suspicion that this patient with a renal tumor can have an IVC thrombus. Again, the gold standard for diagnosing a tumor thrombus would be a cavography. Should always remember the gold standard investigation is usually the most invasive and the most complex. But what we commonly do is, in most cases, you are able to, with the newer CT scans, you can pretty much pick up presence of venous involvement on just CT. And if you're in doubt, an MR venography gives pretty good results. And yes, if you're still in doubt, that will be the gold standard. Traditional venocavography. As I said, renal arteriography or an arteriographic phase, we generally don't tend to do that routinely. We can do it in 25, 30 to 45%. If you're planning to do a preoperative renal artery embolization, which we generally do not do these days, then yes, we do plan to do that. Transesophageal echo, it's useful mainly for intraoperative monitoring of the thrombus, and but also to diagnose an extent of the thrombus. Preoperative angioembolization, we used to do this before, as we was thought to reduce the size of the tumor thrombus, but it increases the risk of complications. So we generally tend not to do that. The only advantage that we thought that it helped us to ligate the vein early if your artery has already been embolized, but these lesions have so many collaterals that even if you ligate the vein before the artery, it does still bleed a lot. And moreover, these days with the use of vascular staplers, you can just go across the hilum with the stapler, which means you don't really have to dissect the artery completely. As long as it's dissected around the hilum on both sides, we just fire a stapler across if these very large tumors. So yes, a preoperative angioembolization was done before with lesion that was actively bleeding, just invading the IVC or invading level 3 or 4 which could not be excised, with more as a palliative approach. Because of these complications, it is not routinely performed, and it also causes tumor lysis syndrome, which is very difficult to manage. As I said, that used to be an advantage, but with the use of staplers now, it's not very much so. Tissue plain edema, it does help for surgery, but that alone can cell salvage helps us get around this. So essentially, there are safer ways to achieve these advantages now compared other than preoperative angioembolization. So it's not something regularly performed. Reasons we would perform then if someone has really bad bleeding preoperatively and you want to get them optimized. Yes, that is a very good indication for performing preoperative angioembolization. But apart from that, we generally tend not to. Adrenal involvement, we've seen T4, this contiguous involvement, M1 if it's non-contiguous. So that is adrenal involvement, and if the tumor is well away from the adrenal glands, it can be safely preserved. However, as it says, you've got a PAL, extensively malignant tumor, or you're not able to see the adrenal gland clearly, or if there's any signs of adrenal lesion on CT, then it is safer to remove the adrenal gland, because you always have a normal adrenal gland, or most likely have a normal adrenal gland on the other side. Lymph node involvement, you can sometimes have visible lymph node involvement, anything more than or equal to 2 centimeters, almost always malignant change, but it doesn't necessarily mean less than 2 centimeters will all be normal. The protocol now is that if any obvious lymph nodes, then we excise. If you no role for lymphadenectomy. So as a part of the evaluation, we've seen the investigation of choice. So well, the first line investigation would be a CT abdo-pelvis renal protocol, but we invariably do a CT chest as well, because lungs are the most common site for metastasis for renal tumors. So that's what we do commonly. We don't tend to do other scans unless there are any obvious signs of metastasis. So STAMID SPECT CT scan is now being studied for renal tumors. It's still not completely proved or not exactly found out what protocol works with renal tumors, but it has been shown to be useful. This is a targeted scan that targets carbonic anhydrase 9. Girentuximab, it is used for both if carbonic anhydrase 9 is present or positive, then yes, this can be used as a very good scan, but otherwise it is not very useful. Again, aquaporin and perilipin 2 are other substances that can be useful, but these are all under study. So at the present time, all we do for staging is a CT scan of the chest, abdomen, and pelvis. So when do you do a renal biopsy? You do renal biopsy when your diagnosis is uncertain and will alter management. So it's good to have tissue diagnosis in these cases, but before you decide to embark on surveillance, because certain types of tumors may not be suitable for active surveillance. A metastatic RCC, you do this because to plan for optimal treatment, because some immunotherapies are not suitable for certain types of tumors. So a lymphoma is metastasis. If you suspect a lymphoma or mets, again, you do it essentially to get a diagnosis, and treatment will depend on what type of lymphoma or where the metastasis is from. So how safe is renal? Is quite safe. They previously thought to be a problem, but renal mass biopsy, there has been no significant reports of tumor seeding. It's only done when it will alter treatment or management. You do not do it in someone who's on watchful waiting. You do it for someone who's on active surveillance so that you can make sure that you've chosen the right treatment, not for someone who's on watchful waiting, where you're not going to intervene even if it turns out to be a papillary tumor instead of a clear cell. So the most common complication is bleeding, usually in the form of a hematoma, which settles down on its own. So if the biopsy is positive, yes, but as I said, about 14% are non-diagnostic. So far, we've seen in RCC, we've seen the risk factors, which are hypertension, obesity, and tobacco. We've seen several familial syndromes, chief among which are VLL, we have tuberous sclerosis, familial papillary, HLRCC, Birt-Hort-Tubé syndrome, succinate dehydrogenase, and Cowden syndromes. Then we've seen the pathology, which most commonly is clear cell RCC, papillary RCC, and chromophore RCC. We've seen the investigations, which is a CT, the role of venocavography, and how to stage this disease. And in the staging, we've seen about TNM and how to go about doing this TNM by doing a CT chest, abdomen, and pelvis. So that's what we have seen so far. Moving on next is to the actual treatment. So as I said, treatment is for RCC is quite black and white. There are some so the treatment, there are candidates who can have surgery. That is, you essentially divide them into operable and inoperable. Inoperable tumors are the ones who have metastatic disease with poor prognosis or locally advanced where it's not safe to remove. Anything else is operable, even metastatic tumors with low burden of mets and good performance status. Leave aside the localized and locally advanced tumors, even metastatic tumors who have a very good performance status and a very low burden of mets, they're also operable. So now comes to the question of what surgery do you offer for them? So what are let's see what the options available are. So partial nephrectomy and radical nephrectomy. So these are the two surgical options. They all can be done laparoscopically, they can be done open, they can be done robotic. It depends upon the expertise, but two surgical options are essentially partial nephrectomy and radical nephrectomy. What are the other non-surgical options? We use active surveillance. This is based on the fact that renal tumors grow very slowly in size, and you can use ablation. Ablation can be radiofrequency ablation or cryotherapy. We'll see a little bit about it. So, how do we choose patients between radical nephrectomy and partial nephrectomy? So, one is the staging, TNM. Any T3 or above, yes, they will all most likely have radical nephrectomy. T2 and below, then we need to risk assess to see if they can have a partial nephrectomy. So how do you do this risk assessment? That's where you get these scoring systems, the renal scoring system and the Padua scoring system and the centrality index. There we go, that's the one. So you have different scoring systems to see if you can safely perform partial nephrectomy or not. And one is the renal, where you get radius, whether it's exophytic or endophytic, nearness to the collecting system, anterior, posterior, location related to the polar line. Based on this, you get a score, and then a very high score, then it's a higher risk. You've got different scoring systems. Just remember the names of the scoring system and what they're used for. You use this, and now you get 3D printing, AI, lots of different techniques that are available for you to make a model and plan the surgical treatment from imaging. So that's how the renal complexity scores. Padua is that's the preoperative aspects and dimensions used for anatomical classification of renal tumors. So when do you do partial nephrectomy? So the absolute. So any small renal mass, the gold standard is to perform a partial nephrectomy. It is now clear that radical nephrectomy is an excessive treatment for a small renal mass, where it's feasible for partial nephrectomy. If you don't have the expertise to perform a laparoscopic partial nephrectomy or robotic partial nephrectomy, it is in the best interest to even do an open partial nephrectomy rather than do a laparoscopic radical nephrectomy. So T1A tumor, which is less than 4 centimeters, that is the standard of care. Again, absolutely, although these are relative indications, the absolute indication is if it's in a solitary kidney or if it's a bilateral tumor, yes, you will have to do a partial nephrectomy. Any tumor, someone who's got syndromes who have very high risk of recurrence, yes, you'll do a partial nephrectomy. So this is very important. You only need 20 to 30% of one kidney to avoid end-stage renal disease. So you've got a lot of room to play with. So even in bilateral tumors, you can easily perform a proper partial nephrectomy on both sides and still keep the patient free from dialysis. Let's go up to radical nephrectomy. Radical nephrectomy, wherever you think partial nephrectomy is not feasible, they should have normal kidney and a baseline GFR that will be more than 45. So essentially, they will be CKD3B once you perform a radical nephrectomy. So After radical nephrectomy, there is a compensatory hypertrophy. There will be drop in GFR with proteinuria, which can also cause an increase with cardiovascular events and mortality rates. So surgery, radical nephrectomy is now only performed for tumors where a partial nephrectomy is not feasible for any reason. It could be a complex tumor, it could be a complex patient, which if you cannot safely perform a partial nephrectomy, then the treatment would be a radical nephrectomy. For tumors up to this decision is only for tumors up to the T2 or T2A. Radical nephrectomy is quite simple. All you do is you take kidney with the gyrotest fascia and ureter as low as you safely can. Important thing is to make sure you do not enter through the gyrotest fascia. You can preserve the adrenal glands if the tumor is not close to the adrenal glands, or if there are no abnormalities on the adrenal glands themselves on preoperative imaging. But if in doubt, then it will have to be excised. There is no role for a lymphadenectomy, as I repeatedly said, in radical nephrectomy for RCC. For partial nephrectomy, there are several different techniques. You've got clamp on, which is where you clamp both the renal artery and the vein. There are techniques where you only clamp the renal artery. There are certain small tumors where you can do off clamp approach. This is for just that management of hilum. Then you have the technique of tumor removal themselves. It can be a wedge resection, it can be a segmental resection, it can be just an enucleation. In complex tumors, especially those who have a solitary kidney, then you can remove the kidney, perfuse it, and then auto transplant. What is important is you need to preserve the perirenal fat and renal fascia, which is then covered over to provide hemostasis and support for the tissues to heal. So that's what we say. That is enucleation. This is especially preferred for syndromic cases where you're not very bothered about positive margins. Standard partial nephrectomy is where you do a wedge resection, and we only need a 2 to 3 millimeter margin around the tumors. Even if you get a positive margin, the usual technique is to observe even for non-syndromic cases. And as I said, hypothermia, you do practice that. It's feasible in open approach, but it's difficult to do this for laparoscopic or robotic cases, in which case all they do get is some mannitol and furosemide before the clamping of the renal artery, and we do an artery only clamping. But overall effect on renal function is the same. So if you've got a solitary kidney, you have to absolutely do a partial nephrectomy, but you're not able to, because then you can either remove the kidney and do a renal transplantation, or you can take the kidney out, do an extracorporeal renal surgery, that is ECRS, extracorporeal renal surgery, and then try and do an auto transplant. So we can give a trial of tyrosine kinase inhibitors, but this is not commonly practiced. Then common questions you get postoperatively are based on complications. Two major complications after partial nephrectomy: bleeding and urinary leak. Bleeding, Very simple. You do a selective angioembolization. If that fails, they will need a nephrectomy. Urinary leak, again, it depends on how bad the urine leak is and where the urine leak is from. You will do a CT urogram. You put a ureteric stent in and drain any collections and then observe. Usually this is self-limiting. Drain TJ stent and Foley catheter, it spontaneously heals in 4 to 6 weeks. And we've seen postoperative hemorrhage, selective angioembolization. So what is hyperfiltration injury? It's essentially the spare kidney or the normal kidney being overworked, and it can cause increased proteinuria and FSGS. Treatment for this, ACE inhibitors and low protein diet. We've already discussed this. What do you do for positive surgical margins? They are mostly managed with close surveillance. We've discussed this one. Yes, now coming to ablative therapies. So what we have seen is if someone is going for ablative therapy, it's preferable to do a biopsy before because it's difficult to, if they do get metastatic disease later, it's difficult to plan management. So there are two different types: cryoablation, which is based on cold, RFA, which is based on heat. You can go through the entire technique. It's basically causes necrosis of the cells, and over some period of days to weeks, they die out. And what you need to do afterwards is to do a repeat CEC contrast CT as about 6 to 8 weeks after they've had the ablation to see if there are any enhancing areas. If there are any enhancing areas, then that means you may not have completely ablated the tumor. They all have complications, bleeding being the most common in cryoablation. And it's less common with RFA, but they can have other possible complications. So these patients then get followed up by serial CT scans. You can do a post-ablation biopsy for in case of radiofrequency ablation, but you generally don't tend to do any biopsies for cryotherapy. So it's not done regularly by urologists. With the advent of robotic partial nephrectomy, it's a lot safer just to do that rather than send them for RFA or cryoablation. We do give these options to the patient, and these are especially useful in someone who's elderly and not very fit for surgery. But if someone's that old and has got a small renal mass, they are candidate for active surveillance or watchful waiting anyway. So you don't necessarily go ahead with these treatments. So we've already discussed about lymphadenectomy. It is not needed. Don't get confused, don't read about too much. If you want some extra reading, these are the risk factors. If they have more than 2, then they have a 40% risk of lymph node mets. The only reason to remove lymph nodes would be if there are clinical or radiological nodes positive, then you remove them. Got it? But same cannot be said for IVC thrombus. So lymph nodes, Yes, you don't need to do anything about it, but if there is an IVC thrombus, that has to be removed. How does it present? It can cause lower extremity edema. So we've already said isolated right-sided varicocele, which is not reducing, which is not very common. It's common to have left-sided varicocele, but an isolated right-sided varicocele that's not reducing, very high suspicion of some IVC-related problems. Dilated superficial veins, so generally mean there are collaterals, proteinuria, pulmonary embolism, right atrial mass, and sometimes even non-functioning. Adrenalectomy, large tumors that, if it's more than 10 centimeters, a good chance it's probably invading close to the adrenal gland anyway. So yes, you do need to remove it. Extrarenal extension. Yes, you do need to. Just 1 second, just switch on the lights. There you go. So this bit we've already discussed, tumor thrombus and bland thrombus. Tumor thrombus essentially has got tumor cells in it. These can invade, and bland thrombus, on the other hand, it's just blood coagulum. These are easily swept away. You easily sweep these away with a finger. So what do you do? How do you manage? If you know that someone's on IVC thrombus, yes, you need to start them on some anticoagulation. You can use temporary suprarenal IVC filters, but most commonly, early surgery is what you need to do for these patients. So your TNM stages has just 3. To revise again, T3A, T3D, and T3C. So this is just the renal vein. This is IVC below diaphragm, and this is IVC above diaphragm. So that is the level of the vein. On the other hand, there's a separate classification. If it's confined to the renal vein, you can easily do a radical nephrectomy. If it's within 2 centimeters of the renal vein ostium, you can easily milk it out, or you can even do a partial IVC occlusion with the Satinsky and take it out. If it extends up to the lower aspect of the liver, then you need to get help from your vascular colleagues, or do a complete IVC mobilization and control of all the different IVC branches. It's between so level 3, it's between the hepatic veins and the diaphragm. Then you need to do suprahepatic IVC clamping. If it's gone above the diaphragm, then you need to do a formal cardiopulmonary bypass. So what's more important for you is the sequence in which you clamp the veins. For simple thrombi that are below the level of the hepatic or the liver, what you do is you clamp the infrarenal IVC, clamp the contralateral vein and the suprarenal IVC, and the clamps come off in the same way. So if there's invasion of IVC by tumor thrombus, then you can do an aggressive resection of the involved cava. Sometimes you may have to resect and graft the cava. If it is a complete occlusion, you may not need a graft. There will be a lot of collaterals, so you may not even need a graft in those cases. So from your point of view, what you need to know for the exams is what are the levels of IVC thrombus, both on a TNM stage and just the surgical levels, which will be 0, 1, 2, 3, and 4. Renal vein, less than 2 centimeters from ostium, below liver, below diaphragm, above diaphragm, form of clamping, and what are the complications? You can have air embolism, you can have hepatic dysfunction, you can have organ ischemia. So what is the role of neoadjuvant and adjuvant treatment? It is still investigational at the moment. For locally advanced tumors, there is no role for neoadjuvant or adjuvant therapy, and it's all only investigational. On the other hand, for metastatic disease, all need immuno or targeted therapy. Question is whether you do a cytoreductive nephrectomy or not. There is no question that they all need to be started on immunotherapy or targeted therapy for metastatic disease. The question is whether they need to have a cytoreductive nephrectomy or not. So I'm not going to go into detail about the different options for immunotherapy, and just briefly touch upon it. Before we go there, what is the local recurrence rate? Then nephron sparing surgery, it's about 1 to 2%. After radical nephrectomy, it's about 2 to 4%. Local recurrence is generally higher after you do thermoablative therapies. And the management will depend upon if they have metastatic tumors or not. You have the MSKCC risk stratification, or what's called as the Mozart criteria, to decide whether patients will benefit with metastatic RCC, will benefit from the resection of cytoreductive nephrectomy or not. So yes, the treatment options are cytoreductive nephrectomy, metastectomy if they have a very limited metastatic burden, and palliative nephrectomy if they do not have, if they have horrible symptoms, in which case the performance status does not matter. So that's the criteria for historical criteria for immunotherapy. It was called as the Mozart criteria. It's a performance status less than 80. These are the risk factors, essentially. Presence of more than one risk factor, 1 or more, it's intermediate risk, and 3 or more, and that's the survival. It's there in Campbell, but I'll leave it on screen for a minute if you want to. Now, so this was in the era of immunotherapy, which is interleukins, IL-2, not when they were not with targeted therapy, which is what is more commonly used now. So they have revised the criteria for targeted therapy, which is range of treatments, and you can see that survival has clearly improved with the targeted therapy. The risk factors are roughly the same, performance status, but there are a few different. Calcium, but hemoglobin is the same, neutrophilia, thrombocytosis, and time from diagnosis to targeted therapy is slightly different. And there are 6 risk factors now compared to 5 before. So when can you do a cytoreductive nephrectomy? So number 1, they should have limited metastatic burden. Number two, tumor should be easily operable, and they should have a very good performance status. So in general, good risk patients who fall into this good risk rating category and at a stretch may be intermediate with just one risk factor, yes, you would consider doing a cytoreductive nephrectomy, and these patients may have a survival benefit if you do a cytoreductive nephrectomy. What's the reason behind it? Something called the Lazarus effect, where we have seen mets regress after nephrectomy. It happens in less than 1%. Very large tumors, they inhibit T cell function, and again, very large tumors act as a cytokine sink where all of your treatment. So there's not a very great response in the primary tumor itself as a result, because all the treatment gets concentrated there. There's not a great response with the meds as well. Okay. Palliative nephrectomy, here we're not talking about risk factors because you're doing it for symptomatic relief. See that one with a bit of color. So here we go. There are different targets for treatments for RCC. You've got everolimus, temsirolimus, which act through the mTOR pathway. You've got VEGF inhibitors, which can be at the level of the receptor, the ligand, which is bevacizumab. It can be at the level of the receptors, which is pazopanib, axitinib, and cabozantinib. PDGF, this was used before. Nowadays, this is not first line anymore. These have now become the new first line treatment. VEGF inhibition is now current first line treatment. And again, you have so many different drugs: sunitinib, sorafenib, pazopanib, axitinib, Linvet, and there's lots and lots and lots that come out each day. As I said, the guidelines or the textbooks still say sunitinib is among the first line. Very rarely do people use sunitinib anymore. Again, there is brief description about each of these drugs. You need to remember what they act against and what their side effects are. So it's just different drugs, it's pharmacology, and fortunately, as I said before, not a lot of different ways to remember this. So coming to, so you've done that. Coming to chemotherapy, we've said no clear role, but where it is helpful is in collecting the RCC. Sarcomatoid variants and collecting duct tumors can sometimes, there we go, collecting duct tumors are the only two areas where you can give chemotherapy. So that's what you need to remember. Don't need to remember what is the chemotherapy, but make sure sarcomatoid and collecting duct carcinoma, yes, you can give chemotherapy. Again, the biliary RCC, the drug name is foritinib. Just make sure you remember that. But there we go. As we said before, different guidelines based on different countries. They all have different specs. Sunitinib is no longer first line, but you can use any of the other drugs as a first line therapy for these patients. Most often it's pazopanib, which is most commonly used nowadays in most countries. And it is usually a combination therapy that contains both immune checkpoint inhibitors, which, as we have seen here, CTLA4, PD1, and PDL1. So these are the immune checkpoint inhibitors. You plus VEGF targeting combination is what is used as first line in most countries now for metastatic renal cell tumors. That's from the 12th edition of Campbell. Nivolumab and ipilimumab is the frontline for intermediate and porous tumors, and there are trials going on every day, and treatment keeps changing every time they release the guidelines. Treatments change. So to finish briefly about metastatic tumors to the kidney, these are actually the most common malignant neoplasm in the kidney, most frequently from lung, breast, and GIT. Multifocal and hypovascular, and she said these are one of the reasons why you must do a biopsy. If you suspect METs, then they will need a biopsy. Even if it is a small renal mass, SRM, which is less than 3 centimeters, we suspect a biopsy, suspect a metastatic disease, METs from elsewhere to the kidney, yes, they will need a biopsy of that lesion. So again, for revision, different syndromes associated, it's all put in a little table for us to read and revise again. I'm not going to go through this, but quick recap of management. It's based on T1 stage. T1, you will have to try and do a partial nephrectomy, unless if it is not feasible, then yes, then you can do a radical nephrectomy. T2, then consider PN, but most likely they will end up needing a radical nephrectomy. T3, you will need to do radical nephrectomy plus IVC or renal vein management, which is based on level of thrombus, and they will most likely need an adrenalectomy as well. T4 disease, it will be a radical nephrectomy, but they will invariably have a recurrence because the tumor has spread outside the geratus fascia. Lymphadenectomy, no role. IVC thrombus, depends on the level. You can do a radical nephrectomy, cavotomy, or a side clamp because it's less than 2 centimeters. Level 2 is lower surface of the liver, but you will need to mobilize. Level 3, you will need suprahepatic clamps or veno-venous bypass. Level 4, you will need a cardiopulmonary bypass. Cryo and RFA. These are essentially for T1A lesions. Anything bigger than that, it is larger than that, they don't have a good response. The recurrence rates are about 10 to 20%. And always do a pre-treatment biopsy before you do cryo-endocrine function, radiofrequency ablation, and monitoring is by CT only for cryo, CT plus biopsy after 1 year if it's RFA. What important to remember, RFA less risk of bleeding. Lastly, metastatic tumors. They will all need some form of targeted therapy, which is delivered in a combination form now, where you combine VEGF with checkpoint inhibitors, most commonly ipilimumab plus nivolumab. Keeps changing, will probably change before your next exams, but in general, combination is what's preferred now. Cytoreductive nephrectomy in good risk patients with low metastatic burden, it can be beneficial. Thank you. As I said, the treatment itself is not very complex. What you need to study is all about the pathology of these tumors and the different syndromes that you'll have to read and memorize, unfortunately. So keep going through it. That's why it keeps coming about 5 or 6 times in the notes. So you keep reading through it again and again. Again, if you feel there's something that's been left over, that's not been discussed in detail, let us know. We can. What we then do is then try and cover all those separately, or it's just small doubts we can clear them as we go. With some additional notes. Okay, thank you.